We're going to talk about vasculitis, and that's exactly what it sounds like. It's vessels that are inflamed. So vasculitides is kind of this broad term. There's over 20 conditions that count as, you can't have that noise. Do that, maybe. Yeah, so there's over 20 conditions that count as like these vasculitides. So generally speaking, these are rare. And I will say, remember when we talk about exam questions and board questions and take homes, I'm not going to ask you the in detail stuff about the diagnosis that happens, to 12 in a million people. So out of this, take a lot of the high level information back. Try not to get too caught up in the weeds here. Some of this is filler. I'll try to point that out. I think it's pretty obvious as we get to those slides. But generally, it's a rare condition. It's inflammation of the blood vessels. We think a lot of these are kind of onto that autoimmune category. And the way we classify these is that they affect arteries or veins and big vessels or small vessels. So you see some examples there, right? The small, medium, and large vessels and kind of how they are classified. That's usually one of the take homes. So as we get into the first one, granulomatosis with polyangiitis, bless you, collective bless you, it's allergy season. Again, a lot of these are rare, 12 in a million people. I mean, I don't know anybody who I've really seen with this or has had this, but again, big star, you want to know that this is a small artery disease. There's a classic triad that you'll see. So upper and lower respiratory tract disease and glomerulonephritis. So kind of the classic picture is these people will have an upper respiratory infection that's just not responding to treatment. And then you'll see systemic symptoms develop. So some of the key things that you might notice, and this can happen late, but that saddle nose deformity. So the nasal cartilage is just completely destroyed by this small vessel disease. So most of these are kind of a necrotizing disease where those vessels are basically dying and the deformity, the lack of the cartilage, the saddle nose. Also, these patients with the glomerulonephritis, they'll have kidney disease that progresses very, very quickly. Like in 2 to 3 weeks, they could end up in kidney failure, all of a sudden out of nowhere. So, the other stuff there is more background, but those are the things that take home from this, right? And it's a small artery disease. You get this destruction of the nasal cartilage, this classic triad, how those patients might present. So if you think about this in, kind of a case vignette, you'll get exactly that. Someone who comes in with a URI, is not responding to treatment, and then they all of a sudden have this rapid kidney disease progress. That's what that's going to look like. If you try to work this up, and most autoimmune things, as we discussed last week, patients go through the ringer. You're throwing every test at them, trying to figure out what's going on, especially these rare things. They're not the first thing that pop on your mind. They're very rarely the thing at the top of your differential list, right? They're lower down just because of the fact that they're less likely overall. But you really need, for all of these vasculitides, you need a biopsy to confirm the diagnosis. So that's a key take home. For all of these, to make the diagnosis, get a biopsy. You can have some high clinical suspicion, especially as you're ruling other things out. But again, you have to get the biopsy, look at the tissue, get the histology to show what's happening. And in this case, it's a lot of vasculitis, the necrosis, and the granulomatosis is this one specifically. All right, you get a head CT, you'll be able to see the chronic sinusitis, the destruction of the cartilage, kind of those other secondary things. If you look at UA, you'll get a proteinuria from that chronic kidney disease or that very acute kidney disease that's causing damage. So basically the labs and workup will support that classic picture. This is going to be kind of a resounding theme for most of these, that early treatment is crucial because these are necrotizing diseases. They're going to cause a lot of problems and cause them quickly. So the easier we can find it or the faster we can find it and treat it, the better the outcomes will be. So it is very, very important to find these as quickly as possible and then treat them as quickly as possible. I'm not too worked up about the phases. I'm not too worked up here about the medication specifically. This is just to show you it can be complicated to treat. This goes into rheumatology. Sometimes it ends up in immunology. The biggest take home here for treatment is a lot of these are going to be steroids. right? For an autoimmune process, if the body is attacking itself, you go and try to turn the immune system off. Say, hey, stop the attack, give high dose steroids. So if you look at this flow chart, it's going to be non-severe disease, corticosteroids, severe disease, high corticosteroids. So either way, that's what you're starting with. That's kind of a resounding theme as we go through vasculitides. All right, so you see the high level, kind of I want you to take from this. Okay. As we get into microscopic polyangiitis, again, this is pretty rare. This is a necrotizing vasculitis of small vessels, which makes sense, right? If it's microscopic, small, okay. There is some of this ANCA associated, again, that tells us it falls probably somewhere in the autoimmune camp. There's not a great understanding of these vasculitides in general. Now, the interesting thing is this is also associated with glomerulonephritis and pulmonary capillariitis. So there is a strong overlap with some of these. The thing is, make sure you can compare and contrast, you know, the classic triad that we just talked about versus maybe some of this. But this is another common cause of pulmonary renal syndromes. So the kind of two main organ systems involved, the lungs and the kidneys. Now, these classic symptoms are different. You're going to get basically purpura is the thing to remember, because that's pretty visible as far as an exam. When you look at someone, it's hard to think of other common causes of purpura. This should be on your mind. And again, they get kind of these chronic other pathology in the lungs and the kidneys. So when you do workup for them, you're going to find some things. All right. Same thing here. Early diagnosis leads to the best outcome. Same thing here. Treat it, steroids. All right, if you look at the bottom, there's an association of this with kind of an eosinophilia. That's called Churg-Strauss syndrome. Again, I'm not going very into the details of these things. You're not going to be seeing these in clinicals every day. If one of you sees one of these vasculitides, you'll see more than me. So we're going kind of big picture, try not to get too hung up. I know it gets really feels nitty gritty quickly, but here's some stuff about the Churg-Strauss syndrome. It's basically it's an eosinophilic granulomatosis, and that's where you can get immunology involved, right? So there's a lot of crossover. With the pulmonary system, again, you get, you know, asthma, sinusitis, a lot of those symptoms, plus some of the renal symptoms. So I'm not going to ask you about the labs, the super details of this. This is just this one has an association with an eosinophilic reaction. All right, we talk about polyarteritis nodosa. This is also rare, 30 in a million. Thing to know, all the things in blue, right? It's a necrotizing arteritis of medium-sized vessels. With that, a lot that you'll see is skin, nerves, mesenteric vessels. So you can imagine kind of what symptoms those patients will get. Back to renal arteries, heart, and the brain. The interesting thing about this, it spares the lungs. So everything else we just said goes after the pulmonary system and renal system. This goes after the renal system. It does not go after the pulmonary system. So that's one important thing as far as comparing, contrasting different vasculitides and most likely what is what. There's also this very strong association in patients with an active hepatitis B infection. You can kind of go about that both ways, right? Someone's got a hep B infection and some of these strange things start happening, there's that strong association. Or if you do see one of these 30 in a million people and diagnose them, probably you should think about working them up for an active hepatitis B infection. So those things go hand in hand. That's something you should think about, you know, here. Now, if it's going after the pulmonary system, it's probably not this. But if there's a lot of other involvement, spares the pulmonary system, well, maybe this is your most likely thing to consider. When people get this, there's kind of this classic picture, and it's because the way it can go after the neurologic system, but their symptoms start with kind of this very slow onset of vague stuff, right? Fever, malaise, weight loss. They'll start complaining of some basically migratory pain in the extremities. Now that sounds like basically everything else we talked about last week in a way, right? So they'll have joint pain, they'll have muscle pains, usually in the calves. And then this neuropathy component. So the very classic early presentation is someone with that picture, but they'll have this systemic illness and an acute foot drop. You know, most of the time when you see something like foot drop, and this is when we get into MSK, it's something neurologic from the spine. With this, it's not going to be, oh, I have back pain and kind of this very classic picture that would also be associated with foot drop. This is going to be a systemic illness, you know, sounds autoimmune and the moving muscle pain, joint pain, and then all of a sudden an acute foot drop for basically no other apparent reason. So that's something to consider. The calf pains, the foot drop. It's fairly classic as far as an early presentation for polyarteritis nodosa. The other thing that you can see, some of the other classic findings, is that levata reticularis, that's basically a lace-like pattern rash. So, you know, the right person, it can almost look like they have lace-like or kind of fishnet stockings on in a way. And that's the distribution and the appearance of that rash, as you can see in the top picture. Again, they don't know exactly why that happens. Maybe blood vessels are spasming as kind of a necrotic process is happening. But because of that, they can get that gangrene in the fingers and toes, usually the distal extremities. They can be prone to a lot of lower extremity ulcers. But that also sounds like peripheral artery disease and, you know, all this other things. So, you know, when you see this, you have to put together different pieces of the puzzle to really see what's going on. But that classic lace-like pattern, the acute foot drop, those are things that you should consider. Also, the way that this attacks the kidneys is they'll have a new onset of hypertension along with all of these other symptoms. And because it does affect the mesenteric arteries, you can get a lot of nausea, vomiting, periumbilical pain, you know, associated with food. So the GI system. Now, when you go to work this up again, you can run a lot of labs. The big things to consider, looking for active Hep B. Like most other things, you have to get a biopsy to make the diagnosis. You treat it with high-dose steroids. So this one has a pretty concrete prognosis. You know, without treatment, the 5-year survival rate is only 10%. With treatment, 5-year survival rate is up to 90%. That's where their early identification and treatment is very, very key. Like, this should look and sound a little familiar. Heard of this? I hope so. Y'all pass peds, so. Yeah, Kawasaki disease. Obviously, we know this is in children. It's that classic strawberry tongue, things like that. But this is a vasculitis. It's a medium vessel disease. So, you know, the tempers thing, we know a lot of that, right? But the rash is directly from the vasculitis. Just keep that in mind. There is some crossover here. I'm not going to ask you in-depth peds questions. We've checked that box, gratefully moved on, all of us, right? So, but you should at least know that this is a vasculitis. It's a medium vessel disease, okay? Now, this is the one that is probably the most common. There will be a board question on this. There will be an exam question on this for sure. So if you're going to look at anyone in detail, it should be this one. So giant cell arteritis, when I learned it, was temporal arteritis. Now, giant cell arteritis, obviously we're talking about large vessels. Okay, so that's good. Previously called temporal arteritis, that's kind of the classic thing, the temporal artery. So a lot of the symptoms are going to be in and around that area, the cranial symptoms. So although this does have a systemic component, basically all the classic questions are going to be asking about that. You'll see a lot of jaw claudication. They get, bless you, tired when they're chewing or eating, their mouth gets tired, like true claudication, like you can get in the extremities from stenosis, which we haven't dove into quite yet. But that's the big key thing to clue into for giant cell or temporal arteritis. There is also a common association with PMR, polymyalgia rheumatica. We'll get to that, but start linking the two of those things in your mind. All right, if they have one, common association with the other. So think of those as a link. This does happen generally in patients who are a little bit older. The classic symptoms are, again, the cranial symptoms, the head symptoms. It's going to be headache, scalp tenderness. So because that temporal artery is much more superficial, literally they'll have tenderness if you palpate over and around that area. That's unusual for a vasculotide, but this one is very classic that you can palpate and elicit some discomfort in that area. They might complain of symptoms like amaurosis fugax. Do you know what that is?
The curtain coming down.
Yes. So it's kind of a transient visual loss, right? We usually associate that with something like a stroke or a TIA. Here's another thing it can be associated with is giant cell arteritis. We think here it's because the lack of blood flow to the retina, right? Similar as it can be in a TIA or a stroke. The downside is when that happens in patients with temporal arteritis, that can be permanent. So another reason to find this early and treat it early. All right, if you look at the smaller box, the non-classic symptoms, there are many other things. Know that it is truly systemic, but classically we're going to focus on kind of those cranial symptoms in that picture. But it is beyond just the temporal artery. It is a chronic, systemic disease. But classic things to focus on, cranial symptoms. If you do a workup for these people, their inflammatory markers like SED rate are going to be very high. Because it is chronic and systemic, you can see something like an anemia. But here's the one difference. Although we want to find it early, treat it early. And although you do need a biopsy to confirm diagnosis, those things are all the same. And the very unique thing about this that is a must know is if you are suspicious your patient has this, you treat them before you confirm what they have. Right? So 2 weeks ago, I stood up here and said, don't give the antibiotics, don't treat it unless you know what you're dealing with. That's probably 90% of the time. This is definitely in the 10% of the time where if you're suspicious this is happening, you treat them as if they have it. Steroids go in ASAP. You're trying to prevent these patients from having permanent blindness. So it is essential that the steroids go in if your clinical suspicion is high. If you're wrong, there's not a big downside. But if you wait to organize and get a biopsy to confirm before you treat them, you could cause permanent blindness in them. That's why this treatment is so different. Make sense? Yeah. So you'll treat them before you confirm. But still, getting a temporal artery biopsy is the gold standard. If you look on ultrasound, again, I don't know anybody who's ever done a temporal artery ultrasound for this. Apparently there's some halo sign. Did any of you ultrasonographers? I had one last year, so he could enlighten all of us for these things. Anyway, he'd also never done a temporal artery ultrasound. So with that, I don't think that's commonly done. That's not my take. But as far as that early and aggressive treatment, it's high dose prednisone, just like all of the other things, right? The downside, the complication you worry about most is blindness, because if it happens, it's permanent. It can be permanent. All right, Behçet disease. This one is interesting because it's a vasculitis that includes all vessel sizes, small, medium, large, and arteries and veins. So it's truly systemic, it's everywhere. Now we think of that, we think about what symptoms that can classically cause. Doesn't make a lot of sense in my head to why, maybe Professor Newman knows. But the hallmark symptom is painful oral aphthous ulcer. All right, sometimes you get those, they're painful, sometimes they're painless. There's seemingly 1,000 things that can cause them, including just having fever. But when you think of every artery, capillary, vein, big, small, large, when everything is inflamed, why that's the hallmark symptom, I don't know, but it is. I can't logic my way into that. It's a good feeling. These patients can also get genital ulcers, not from any HPV diagnosis, but from this. So they'll get a lot of skin and cutaneous lesions. You'll see there's a lot of kind of eye, oral ulcers. So you get uveitis, genital ulcers, maybe oral ulcers that are painful. They've got that necrotic center. That's why they hurt until, you know, kind of nerves are killed. There's no more blood flow, but that's it's necrotic. So it's a very systemic vasculitis. Again, you get the biopsy. You can biopsy the lesions, but you've got to get the biopsy to confirm the diagnosis. And you treat it hydrosteroids. Okay. Pretty decent on vasculitides, considering it sounds like a broken record. There's a couple things within each one, compare and contrast, what size vessels, things like that. Big take home, giant cell arteritis is going to be the most common one that you see. There will be questions on that, guaranteed. All right. Moving right along. And look, we're halfway done with our last PowerPoint for rheumatology. We talk about PMR. This is commonly associated with giant cell arteritis, as we just said. So kind of start linking those two things together. When you think about signs and symptoms of this, you usually get bilateral and symmetric symptoms, which will be pain and stiffness in the shoulders, and then kind of the pelvic girdle, which would be the lower back and hips. Does that sound like anything else we talked about 2 weeks ago? Hint, it does. Do you remember what? Do you remember what it might sound like? What? No. Jill, any ideas? No.
Psoriatics.
A little bit. Psoriatic arthritis is definitely around SI joints, pelvis. But there's an even closer one that is around shoulders and pelvis.
Like the skin.
It is. Yes, polymyositis, dermatomyositis, that progressive muscle weakness with proximal muscle groups. So again, comparing and contrasting a lot of these because they start to sound very, very similar. Right? This one's going to be pain and stiffness. The polymyositis, dermatomyositis, or progressive muscle weakness in those same muscle groups, same areas. So there's, you know, kind of weakness versus pain and stiffness, but the symptoms are going to be kind of in the same areas. So keep that in mind. These patients are going to say, I have trouble combing my hair, putting on a coat, or rising from a chair. That's exactly what your patients are going to tell you with polymyositis and dermatomyositis. They're going to say the same thing. They can't get up from a chair. They're struggling to use those muscle groups. For them, it's because of weakness. For PMR patients, it's mostly because of pain or stiffness. So they're going to have the same effect on their activities of daily living and why they're limited. And what is limited, but the why they're limited are going to be different. Okay. So do note, and I wrote here, note, asterisk, bold, underlined. There is an absence of muscle weakness, and that's where some of your questioning and then your exam to back it up is going to give you the information to differentiate between two things that sound very similar on paper or in patient layman's terms, right? What they can't do. Is it because of weakness or is it because of pain and stiffness? And then you reinforce that with your physical exam, testing strength, testing mobility. Make sense? Yeah. Okay. This can last for many weeks. Basically, you do a lot of things and you can't figure out why this is happening. So they'll have more systemic symptoms at times, fever, weight loss, generalized malaise, which has 1,000 other differentials. So that's why this stuff is hard. So when we work up PMR, you have to get a high clinical suspicion. And then you can get some blood work. And again, you're going to find high inflammatory markers, which fits pretty much everything else in rheumatology. To make the diagnosis, you need to always look for giant cell arteritis. So they're kind of above the neck symptoms, that classic temporal arteritis, giant cell arteritis, right? Tender here, the jaw claudication, asking about that. So rule that in or out is a kind of a co-diagnosis or a secondary diagnosis. And then again, can it be another condition? Yes or no? And if it just kind of seems like this very classic PMR with nothing else it can be, dermatomyositis, polymyositis should always be on your differential for this. Then you treat it with steroids. Good news, you treat a lot of these things with steroids. You can't really go too wrong as choosing that as a treatment of choice. The best news with this is once you put them on steroids, they respond pretty quickly. In a couple of days, they'll think you're the hero. They'll feel 90% better. All right, so you've done the right thing. You get very quick response to steroids here. Abel.
Sorry, I missed what you said about no above the neck symptom.
Because there's such a strong association with temporal arteritis, if you think they have PMR, which is, shoulders, hip girdle, you always need to do an exam and ask classic questions about temporal arteritis, jaw claudication, palpate around the scalp, and kind of go down that road as well.
So is it saying don't diagnose PMR if there's no above it? Like, what does no mean? Or is that supposed to be KN?
I don't know. It's a good question. Why did I write that?
Okay.
I think what I meant is to make a diagnosis, it's a clinical diagnosis, right? There's nothing specifically to be like, yes, you have this, no, you don't. But if you're going to make this clinical diagnosis, make sure there's no secondary or additional giant cell arteritis. So make sure there's no above the neck symptoms as well. I think that's what I meant. Yeah, that makes sense, right? Does it now? All right. Sometimes my notes, they feel like a good idea, like you go back to study and you're like, what did I write? All right, so if we're looking at vasculitis, and I don't expect you to memorize this chart, so don't panic. Some of you like charts, totally cool. We're going basically small, medium, large size vessels. I'm not super worried with the ANCA associations and not, that's very deep into rheumatology and immunology. But if you want to use a chart to kind of see where you're going to go, here's a chart where maybe you can do that. All right, moving on to more fun stuff. Osteomyelitis. This is basically a bone infection, so an active infection within a bone. And there's 3 ways this pretty much happens. Hematogenous spread, so it goes through the bloodstream from one place to another. Contiguous focus of infection, where it kind of just anatomically directly moved straight across from skin into bone through like an ulcerated area. That also can cross over with some skin breakdown and then a vascular insufficiency. So there is some link between vasculitis there and osteomyelitis, because bone has vasculature, right? If necrotizing vasculitis is happening, dead tissue is essentially a breeding ground for infection. And those vasculitides, necrotic tissue, what's in and around bone, it can cause a secondary osteomyelitis. So here's some pictures. Yeah. Now I feel about feet. Now you know why. Just kidding. But as far as different types of spread, the hematogenous spread, and you'll notice all of these have some association with diabetic patients. But that's if there is kind of an infection in one place and it goes through the bloodstream somewhere else. Usually that's Staph aureus. Hopefully it's not MRSA. But if you're empirically treating something, you're going to treat them for Staph. We're back in the camp of it's very important to know what you're dealing with before you treat. So a culture, a swab, something to send to the micro lab. And then if you're gonna start empiric treatment after that, you usually treat for staph. First, contiguous spread. This is something that I see clinically in joint replacement. You know, when we put in a joint replacement, it's metal and plastic. There's no immune system there. So it's a very easy place for bacteria to hide. Especially some of the implants that we put in have this kind of very porous metal surface and coating, and it's a great place for bacteria to hide and hang out. It's like wearing a shield all the time. So that's when you see kind of this contiguous focus of infection. This is associated with septic arthritis, which we did talk about 2 weeks ago. This could be cellulitis that goes through the skin and just ends up deeper in the bone. Then we have the vascular associations. And again, your diabetic patients are there because they have a lot of chronic, you know, insufficiency, venous insufficiency, arterial, you know, plaques and buildups there. The downside about the vascular insufficiency, these are all very dramatic pictures, but people with vascular insufficiency, they can have osteomyelitis. And if you're looking kind of at ulcers or at the area over where the osteomyelitis is, it's rarely going to look as impressive as this. So it might look like nothing, and it's really quite something. You do labs in a patient with osteomyelitis. Again, your labs are going to be elevated for inflammatory markers, sed rate and CRP. Those are very, very sensitive. They are not specific at all. What you can use them for in an osteomyelitis is tracking response to treatment. So once you start treating this, you should see the inflammatory levels go down as treatment starts working. How do you find this? It can be variable. Sometimes it is just very dramatic. So, you know, the wrist on top, that's pretty dramatic. Something is infected, right? Red, warm, swollen, tender. I mean, nobody's going to look at that and be like, yeah, I think it's fine. You probably have a bug bite, right? We know that's abnormal. The picture on the top left is one of my patients. You know, she weighed about 100 pounds. You can kind of see the size of her other, you know, limbs, at least the rest of her leg. And she came in because she was worried about the bump on the side of her knee and she didn't like the way that it looked. She otherwise felt completely fine. Clearly, I took a look at that and said, oh, something is really very wrong. You can see where I aspirated that, where that Band-Aid is. And I took, I don't know, I took at least 50, 60 cc's of just straight up pus right out of her knee. So that's superficial. I didn't put the needle in her bone, obviously, but an underlying osteomyelitis was there. So just because it's in the bone, it doesn't always come out like this, but it usually there's some association. This is a rather late finding, but it's going to come out. So you can see her scar. She had a knee replacement there. That leads to a very complicated treatment. But if you're looking for osteomyelitis, sometimes you find it this way, right? Patients will come in and be like, this is weird. And you're like, yes, it is very weird. Sometimes you don't really know, but you can find it on x-ray and you can find it quickly. So it takes about 2 weeks for an active bone infection to change an x-ray image. If you look closely at the picture of the foot, you know, an active infection in bone kind of eat away at the bone. So you'll see erosion where the bone just disappears. That's the biggest thing. If you look where some of those areas are, the bone has just kind of vanished into thin air because the bacteria has broken it down and dissolved it. So you can find osteomyelitis on an x-ray. In some cases, and I think it's more rare, but you can find that without patients having true symptoms. It's more rare, but they can have a subclinical osteomyelitis. So you might see that x-ray and go, oh, we're at the end of the tailbone. So, and that's how you get suspicious, like, is something going on in here? You run some labs, look at inflammatory markers, and then go from there looking for a cause. You ask a lot of history. Do you have this other infection? Has this ever happened? Are you diabetic? Let me look at the rest of you and see, did something get in that doesn't look like much, but has actually caused that?
So is X-ray
the per imaging?
I don't know that there's a gold standard imaging. Truly. I wish I had a picture of her knee because part of her bone was just gone, like chunks of bone were just gone. It depends, I think, at what stage you see them. So if you see someone like her, obviously I kind of know what's going on because I have a culture. Do I need imaging? Not really. What then I need imaging for in her is surgical planing. And so as far as imaging, MRI is the most sensitive that can find it earliest. Now, in someone like her, do I need an MRI? No, I know what's going on. MRI is not going to give me kind of the best picture anyway. For her, X-ray is best. So there's not a true gold standard, but the most sensitive thing, the earliest thing to use would be MRI. CT is generally good at looking for bone. It's usually occult bony fractures. This is going to be fairly widespread. Won't use that as much. But the other thing is a bone scan. So again, it goes back to the why. If she's got this going on and we're not sure why, if you see something and you're not sure why, you can send someone for a bone scan. You remember what that is? You have diagnostics? Yeah, you put in the stuff and you scan them and you got kind of the little pictures of like the whole skeleton, like all these like Halloween photos, right? And wherever the osteomyelitis is or that, you know, continuous uptake, all of that kind of activity lights up white. And so you can find, is it local in one spot? Can you find a primary area? And maybe it was hematogenious spread. So you can see exactly where it is. So bone scan is also used depending on what you're looking for in the patient in front of you. That MRI is the most sensitive. Here, like you see in that picture, we're back in the camp of get the cultures first, then treat it. You know, but when you do treat it aggressively because these patients can get septic. And when patients are septic, they don't always make it. They get very, very sick very, very quickly. You can do a bone biopsy. I've never done that. Usually I'm sending blood cultures because I'm worried about them being septic. So if I send a blood culture and there's active bacteria that will grow out of their blood, then we have basically a septic patient. And some have fever shows the whole thing, you know, declining stats. Some don't, but they will in about 24 hours if they don't yet. They will get sick very, very quickly. All right. The downside, if you try to culture like an ulcer, a fistula, they're not as reliable. Why not? Like if we go back to these ugly pictures and I cultured one of those things and sent it and said, okay, I'm gonna start my antibiotics. Why isn't that as good of an idea as doing something like getting fluid or getting bone for culture? Contamination. So what are you probably gonna find culturing this? Everything, yeah, a lot. You're definitely gonna find staph, which is what we're expecting to find in a normal patient. We're expecting to find kind of propagating staph epidermidis. You'll probably find everything. So this muddies the waters because if you culture this and send it and they find everything, then you're starting your patient on 5 broad spectrum antibiotics to cover all of those things. They're obviously septic or about to be. You know, you'll take out their kidneys in no time, trying to save them. So try to be very diligent in what you do and why. If you can culture just the actual positive organism, that's going to save you an infectious disease a lot of trouble, but it's truly better for your patient, you know, as far as their treatment and their overall health. Because they'll have you be alive, but they'll be on dialysis every day versus, you know, whatever. If it's not necessary and you have the ability to truly get a good culture or do a good biopsy, probably the way to go instead of staying superficial. Thanks. Here's another patient. This is signed and prep for OR, as you can see with the initials on the knee. So this was someone, it didn't really look like much, but she came in for some swelling and some very non-specific symptoms. And I aspirated her knee in the office. Basically, everything you see me squeezing out there came out in the syringe, so very quickly we knew what was happening. She wasn't quite septic. She had very early non-specific symptoms. Mostly it was pain and swelling is what she came in for. Her knee was a little warm. A lot of patients, I mean, I don't remember the details, but by judging by her incision, you know, she's within 3 to 4 months of surgery. And at that point, there's already a lot of natural warmth around it because healing is still happening. So as soon as I pulled that out in the incision in the syringe, I thought, oh no, we have a large problem. So sent that to the lab. We just direct admitted her, started her on IV antibiotics, and took her to surgery the next day. But this was kind of when she was prepped for surgery and ready. You could see I was trying to squeeze out as much of that as possible. It does make very impressive photos, but selfishly too, if you're standing there in surgery and you open the knee with a scalpel, this is under pressure, it will soak you.
Right.
Wouldn't recommend, even though I had all my stuff on. I don't want to be wearing that for an hour or two. So, you know, sometimes it doesn't look like much visibly. It doesn't sound like much from the patient. If you really look, it can be quite impressive. And she did have not only a septic knee, kind of a joint infection, but osteomyelitis underneath. So with metal and plastic in her knee, we ended up going in. We had to take all the metal and plastic out because it can't stay there. It's now kind of got this biofilm of, you know, infection that's kind of taken over that. So that has to come out, have to debride and scrape out all the infected, gnarly looking bone. And to kind of make the space stay in her knee, we put in essentially a hunk of cement and we put antibiotics even in cement. This is a really awful thing for patients to go through in general, but especially if they have joint replacement, metal, plastic, other hardware of some sort and in and around that area. But if someone's got metal in them, that's usually the first place bacteria will go. It's another thing we look at patients' dentition. We'll talk about that when we get into surgery. Some patients need a dental clearance because if they have anything active going on here, like I showed you the picture 2 weeks ago, the surgeon with the abscess starting who had the hip replacement. It's the reason that we put him on those IV antibiotics in Cuba because we're afraid of something like this happening to his hip. Because our normal barriers, right, mucous membranes are the barriers of the outside and the inside. But in the mouth and gums, you don't really have that clean protective layer, right? That's a direct source to the bloodstream. So that's why we get so concerned about dental issues leading to this. So sometimes when the patient comes in and they don't have a very impressive history, or we find this and we don't know why, that's some of the line of questioning that we go into. Did any dental work recently? Did you have any, you know, dental abscess, or did you have a root canal? You know, do you have any extensive dental work? And that sometimes is the cause for this.
I actually had a patient in Durham that came to us for something mouth related, from her prosthetic jaw, because she ended up losing her jaw. She was an IV drug user and it infected, she got an infection in her mouth and it ended up infecting her mandible.
Yeah.
And they took the whole thing out and she had a prosthetic and then the same thing happened to that. So she kept getting these like recurrent mouth sores that she kept coming to outpatient derm for, but there's nothing we can do for that.
Yeah, that's really tricky because you can get in this cycle, as you're saying. And you know, IV drug use is something from the outside in. If you're not using clean needles, you're basically self-inoculating right to the bloodstream. Hematogenous spread is going to be right to whatever metal is implanted. But that's hard. Yeah, same thing. You have to take the metal out, maybe try a prosthetic, but it can turn into a chronic osteomyelitis, and those patients really struggle. And it's hard to find a good answer to help them. Oh, thanks for sharing. That's, you know, thought about that. I didn't know you had a face in
Didn't look great.
no. All right, well, as far as this, osteomyelitis, so it can happen in any bone, you know, but you do have to debride and get rid of that dead tissue. A lot of times you're taking stuff like that out. These patients are on a long-term antibiotic, so they usually get a PICC line right away. They'll have kind of, you know, constant either infusion or they'll be doing 2 or 3 times a day, different regimens. Then they can go to oral medication. It's usually a minimum of 12 weeks, so 3 months of some type of antibiotic. You can watch their SED rate and CRP inflammatory markers. as you go on. And then you might do, we do before we put another metal and plastic implant in, is we'll after the 3 months, kind of give them a drug holiday. So we wait another 4 to 6 weeks. And we wait to see if anything refesters before we put metal and plastic in again. Sometimes it does, sometimes it doesn't. Sometimes we're doing more aspirations and more biopsies just to see if the culture will then still grow anything before we'll put more metal and plastic back. All right, as far as the prognosis, it really depends how soon you find it. Some people end up being on chronic suppression. So they're on antibiotics every day of their life to keep osteomyelitis kind of localized or subclinical. And those are, again, a lot of diabetic patients with ulcerations of some kind. Okay. All right, thoughts or questions? All right, we're going to blow through a couple more of these. This gets more into the immunology route. So we're not going to deep dive into a lot of these. Don't let your brains get too twisted. But selective immunoglobulin A deficiency is the most common primary immunodeficiency disorder. There's some type of genetic component here. And basically, it's when your patient doesn't have levels that are detectable of IgA. So anything less than 7 is considered undetectable, but they will have normal IgG and IgMs. So again, very immunology forward. Most patients won't know to have this, but they are more likely to get infections, specifically respiratory infections. So sinus issues, ear infections, bronchitis. If they're chronically getting that, this is something to maybe consider. But again, if you know your patient has this and you're giving a blood transfusion, that's something to be very careful about. You can accidentally give them a transfusion reaction, which will send them into anaphylaxis. This is treated by an immunologist. This is kind of in detail. But if you're working in ENT, which is a specialty of its own, and you're seeing these chronic patients, they're sick all the time for basically no good reason, and you can't seem to clear these up well or quickly, that might be a referral to immunology to look for this. All right, that's the most common one, which I've starred. There's many, many more that we will acknowledge they exist, and that's about it. Okay, so we're not going to get into the things that are not blue on this chart, but know that there's a lot more as far as immunodeficiency syndromes that have a strong genetic component. Again, we're sticking with the IgA one. So IgA less than 7, IgG, IgM's normal, causes more likely to, kind of those URIs, the sinusitis, otitis, chronic. That's the stuff to know. That's the take home. All right, some of these patients, you'll give them antibiotics at home. Like if you start having symptoms, start your Bactrim right away, start this right away. Or, usually for sinus infection, we can tell patients, these are self-resolving, do your symptomatic treatment. These patients get antibiotics, you treat them early, they'll call you, you take their word for it and just give them the antibiotics. So we treat them a little more aggressively than the average patient because we're supplementing that they're missing this part of their immune system, if you will. Okay. If you like charts, here's a bunch of charts. Moving on. I think you have what you need to know about that. Serum sickness. Does anybody know what this is? Have you heard of this? You've probably heard of it, just not in this specific word. So this is when the classic presentation of this in a question on your boards, it'll be on your boards, is someone gets an anti-venom, usually for a snake bite. And then a couple weeks after that, they get all this crazy immune response. So that's kind of what these questions usually look like. All right, so someone will get an antibody kind of administered exogenously, usually some type of anti-venom. And they have this delayed hypersensitivity reaction. All right, it's usually from this kind of non-human species. That's the anti-venom. It's usually from a snake bite. But they'll get this high fever. They'll get this crazy rash. They can get arthralgias, myalgias, lymphadenopathy. They can get nephritis. So they get this very big systemic reaction. It is luckily self-limited. Once again, if it's severe, put them on steroids. The thing is to identify if this is happening from something that's not anti-venom, bless you, stop the drug. That makes common sense, right? But if it is severe, this is steroids, but it's usually delayed. So it's not gonna be you give someone anti-venom at noon and at 1 o'clock, this is happening. This is usually a week or two later. Usually the patient will not make the link of what happened and these systemic symptoms. This is where, again, going back to patient history, you as the provider have to tease this out and then make the link. Kind of knowing that this exists, and it depends where you work. If you work kind of in rural medicine, if you work like one of my colleagues in El Paso, Texas, you'll probably see this. You work here, knock on wood, probably not, hopefully not. But if your patients travel history, social history, these are things maybe to tease out. A lot of the rheumatology, immunology, right? They're not very clear cut. You have to do a lot of the reaching and stretching. So being aware of some of these things are pretty important. Along from serum sickness, there's a lot of other things. Like, did you learn about erythema multiforme? Yeah, so you learned about that. Stevens-Johnson syndrome, you learned about that? Yeah. I will tell you a story. I had Stevens-Johnson syndrome. I wasn't smart enough to figure it out. This was years ago. Most of you know, I had sinus surgery in January. That was the third one. I'm almost the IgA person where my sinuses are a mess, my allergies are a mess. I've had really weird sicknesses where I've been on hydrosprin in my life for a long time. And a couple of years ago, it was pre-COVID, so I know a couple of years ago, I was on Bactrim for a really awful sinus infection. I woke up one morning, my face looked like it had been stung by 1,000 bees. I had the angioedema, like all of this crazy stuff was happening. I was starting to get a lot of, I guess they weren't quite vesicles, but they were like ulcerated vesicles, like a lot of my hands. I had lymphadenopathy to the point where I was like actually struggling to breathe. I thought that I might have tonsillar abscess, and I'd been sick. So I was on the Bactrim, and I did go to the emergency room. They made sure I wasn't going to die instantly, which is great. Started me in the high dose steroids. But it was one of my friends from P school who works in primary care medicine. She's a hospitalist. She's much smarter than I am. It was like, wait, what did you say you were taking for your sinus infection? And I kind of go through the same 3 or 4 drugs and all these 4th generation cephalosporins, and we switch it up every once in a while. And I was working in a hospital, so probably a MRSA carrier and all this stuff. I said, oh, I'm on Bactrim. She's like, you dummy. This is from the Bactrim. And so they diagnosed me with SJS, and I've never taken Bactrim since, but I've taken Bactrim 1,000 times before that. I will not show you a picture of my face. I have it somewhere, and it's so awful. So sorry. I did share with my colleagues at the time. They were like, whoa, I know you. And that does not even look like you. But, it can be dramatic. But again, I literally was the patient and didn't make the link of what was happening. I've been on Bactrim 1,000 times, right? I didn't have allergies, so to medications, but like these weird things with immunology can pop up. And so just trying to keep an open mind. It took my friend who's much smarter than me to figure out what was going on. So that's my claim to fame within this. But think about serum sickness. Those patients also will not put 2 and 2 together and come to you and say, yeah, hey, Nick, so 3 weeks ago, I was hiking here and we think I got a bite. So they gave me this stuff and everything was fine and blah, blah, blah. And now I have all of these symptoms. Do you think, if they're a good Googler, they may come to you with that, but it's rare that people will make this link together, right? I just thought really a bad sinus infection. I've got this other stuff, all these things going on. You're not feeling well. So, I will say in my world, episode of 60 fixes a lot of things, but anyway. All right, why don't you guys take a 10-minute break and then we'll pop back. It's 8:59. We'll start at 9:10. Kind of still, area we're trying to pin this down in terms of where does it kind of belong, if you will, within the medical scope. But when you talk about chronic fatigue, this has been renamed officially. You'll still probably hear most people, like I learned it was chronic fatigue. A lot of practitioners are going to call it chronic fatigue syndrome. But the other name for it that you might start seeing or be aware of, it kind of has 2 names now. for systemic exertion intolerance disease, so SEID. That is the same. So these are pretty interchangeable. Some people will kind of use this new term, but I will just say clinically, I don't think this is really caught on. So a lot of patients who have this diagnosis will just still tell you as a provider, I have been diagnosed with chronic fatigue syndrome. If they say I have SEID, most other providers won't know what that is. So even patients kind of are still using the classic term. There's 3 general components. Those I recommend you know. All right, the generalized weakness, I wrote them down for you. Generalized weakness, easy fatigability, and then mental fatigue. And then next to that, that's kind of how that would come out in their story, right? They're not going to say, I have mental fatigue and easy fatigability. They're going to say, yeah, I just don't feel like starting stuff. I'm just so exhausted, I can't finish everything I start to do. My concentration is going. And when it comes out like that, in terms of, you know, how patients are going to present to you in their layman's terms and their HBI and their chief complaints, when you think about differentials, you know, it's a lot of rheumatology that we just covered. It's a lot of kind of some psych things that you guys have also covered. And so it's hard to really pin this down. There's a long list of differentials, but with that, this is last on the list. So you have to go through all of those other things on your differential list and rule them out. So a lot of them, you can do different labs and things and kind of rule things in or out. Sometimes they're seeing a psychiatrist, rule things in or out. So the patients who end up with this diagnosis, like most autoimmune disease, have gone through an extensive workout. It's taken years. They kind of are treated as, quote, the crazy patient is what they'll tell you, or they feel very brushed off. So they'll go through this extensive workup and still come up empty-handed with nothing. So this ends up being a diagnosis of exclusion, and there's no gold standard for diagnosing someone with this. There's no diagnostic criteria, there's no labs, but, you know, generally they'll either have co-diagnoses with some of the other things there, or maybe misdiagnosed or kind of worked up for all this other stuff, right? Insomnia, hypersomnolence, narcolepsy, you know, sleep apnea, you know, different insomnia things, you know, restless legs, substance use, abuse, medication side effects. So they'll really go through the ringer before they get here. So remember those 3 components, right? There's got to be a substantial reduction or impairment for any of those things there about what they can start, their easy fatigability, their post-exertional malaise, and their kind of unrefreshing sleep, and one of the following, cognitive impairment or orthostatic impairment. But, you know, if I joke a little bit, and then if I look through these, I think all of you could probably self-diagnose with this at this very moment, right? Am I wrong? Does anybody feel like for more than 6 months, you had a substantial reduction or impairment, you know, that's not substantially alleviated by rest in what you're doing during the day.
Yeah.
You have post-class or post-exertional malaise and unrefreshing sleep, right? Do you feel some level of cognitive impairment? So I kind of say this in jest, but the point is, these are very broad things. And so I'm able to kind of pin this down as a diagnosis of exclusion. There's no gold standard. It's very frustrating when patients are going through this workup. So if you look at, I guess, kind of the algorithm or the chart there, do a full H&P. You know, if that's normal, you get a bunch of tests. If that's normal, mental status. If that's normal, more labs. If that's normal, then maybe you start thinking about this or putting it on the list. But this is fairly idiopathic. We can't find a reason or why. It's not genetic specifically. There's, you know, none of those links that we can put to this. So, you know, again, this is kind of meant to be a little funny, but this is really what patients are going to be like, great, here we go. Everything's normal. And normally when we're doing labs or workup, you know, we want normal results, but to these people, they're just looking for some answers. So they are oftentimes more frustrated when things are normal, because for them, that means no answers. So keep that in mind as patients are going through this. And then in order to treat them, it's pretty multimodal. You're going to treat the symptoms as best as you can. It's a lot of lifestyle, education, and encouragement. And then for meds, you can, you know, try a bunch of things, but these patients are going to be the, you know, try this, try that. And then they feel like the lab guinea pig, right? Because you're just throwing things at them, hoping something sticks, but nothing is really definitive treatment. There's no gold standard treatment. There's a lot of things they do. So it's very difficult for patients to live with this diagnosis, and they do have this general label, right? So same thing with fibromyalgia. This one gets kind of the red flag label, right? A lot of patients with this diagnosis feel the same way. This is a chronic condition. It's non-inflammatory. And basically there's global body pain. So that's the biggest differentiator. Kind of pain is one of their main symptoms, where chronic fatigue is more weakness, the tiredability, some of that cognitive stuff. This is going to be that pain component. So big compare contrast there. They'll have fatigue, sleep problems, and this one more likely has an association with anxiety or depression. So is that because of everything they go through, living with chronic pain and being treated like the red flag patient? Maybe. We don't know what causes this, but the secondary name for this is fibromyositis. So again, there's kind of a move to relabel some of these diagnoses like chronic fatigue syndrome, fibromyalgia is now fibromyositis. The tricky thing about this myositis is there's no inflammatory component to this, okay? So we think a lot of autoimmune, and we kind of put this a little bit in that camp. We think true autoimmune, the body's attacking itself, a lot of inflammatory things. This is a non-inflammatory process. The classic signs and symptoms, again, this is chronic. It's got to be greater than 3 months of multifocal pain. So multifocal pain means both above and below the waist, and laterality, right and left sides of the body. So kind of north, south, east, west. You have to hit all of those to have multifocal pain. Again, the fatigue, sleep disturbance, difficulty concentrating. So that's where there's a lot that sounds like chronic fatigue. They're going to have just other unexplained symptoms where they're telling you they can't complete their quality of or daily living, and it's affecting their quality of life. That's maybe where some of that anxiety and depression component can come in. Again, diagnosis of exclusion, because of the pain index, there's a lot of people that end up in the musculoskeletal, you know, looking at the orthopedics and things like that, that basically get told the same thing. Well, your x-rays look good and this looks good, and try PT, try these NSAIDs, I don't know, try this injection, and nothing really helps. So they'll go through all the conservative stuff and they get a lot of the answers of looks good, looks good, looks good, can't find anything wrong. To treat them, again, it's a lot of the healthy lifestyle encouragement, patient education. You can throw in some secondary meds, see if they stick, see if they help, but nothing specifically is, you know, kind of gold standard for treatment. And this is kind of a very controversial diagnosis. We find a lot of kind of anesthesiologists who work in pain control, pain management. A lot of people in MSK will say, this isn't real. So you hear a lot of that. And so when your patient comes in, you know, they're going to feel like the target already. There's kind of this idea when you're working up a patient, they can be misdiagnosed with this because there is some sense of urgency to just give someone an, you know, a diagnosis they can hold on to explain what's going on. So maybe this was overdiagnosed for a while. As far as diagnostic criteria, you know, everything's pretty much going to come up normal, but there's 3 conditions to make this diagnosis. You have to have a widespread pain index score and a symptom severity score that you add up. So I have that on the net. Oh, I have that here, I guess. The widespread pain index is you have the patient fill out a chart. You know, fibromyalgia has these different kind of hot spots or very specifically tender spots, where sometimes you'll push on it and they'll act like you've just stabbed them and you just lightly palpated. But if you find that one spot, you know, they're highlighted there, they're going to kind of react out of proportion to what your exam should reveal. So you're looking for those pain scores above and below the waist, right and left laterality, and then a symptom severity score. So it's like a lot of the site components can do that, right? How much is it affecting this and that and whatever. You want to look and make sure they have chronic symptoms, so at least 3 months. And then again, you've ruled out everything else, so you don't know what else it could be. If nothing else explains it, plus you. So there's the diagnosis kind of at the bottom. Because it's non-inflammatory, their sed rate and CRP should be normal, right? There's no chronic systemic inflammatory pathology happening there. So here, I've given you a DIY chart. If you want to use this as studying, this might be helpful as you prepare for your quiz and then in 2 weeks your exam. To look at vasculitides and a size, classic signs and symptoms, some labs, any other notes. If you have questions, feel free to come to me because I have filled this out myself. Can be done. You look quickly. There's not a ton of things there. I don't expect you to put everything in there. But if you like charts, made the charts, you can set it up. I don't know why something is overlying here, but. As far as DIY clinical pearls, if you go through the other stuff, you can just jot notes. This is an easy way to compare and contrast. A lot of rheumatology, some of the immunology starts to sound the same. All the vasculitides pretty much sound the same. A lot of diagnosis and treatment is the same, but in a clinical picture, can you differentiate what is what based on a couple keywords or, knowing what makes what different? And then same thing, chronic fatigue and fibromyalgia. Right, so the pain is going to be really the fibromyalgia differentiator from chronic fatigue. Yay.